Welcome everybody. This is a tutorial on how to scribe for a medical consultation at the Good Samaritan Clinic. Note that this tutorial is tailored to the Good Samaritan Clinic, so while some parts will be applicable to most medical scribing, some will not. Okay, so we're going to break this down into 3 separate parts. My recommendation is that you follow along on a computer near you if you have a login so that you can learn by doing as well as listening. Some features will not be editable on your account because you don't have administrative or medical privileges, but my screen will look exactly like what your provider's screen looks like, with one slight difference that I'll show you later. So the 3 parts are before, during, and after the consultation. So let's get started. Before the first consult, you're going to need to introduce yourself to the provider and let them know that you're here to help them, however much or little they want, except for a couple small tasks. Our providers are all very friendly and patient with young learners we have in the clinic, so if this is your first time scribing, try not to stress too much. We want you to be as proactive as you can in your relationships with the providers you scribe for. If you don't know if they want something written in a certain way or you're not sure you heard him or her correctly, say something. It should definitely be at the right time, but you still want to ask. It's possible that your provider will not want a scribe for some portion of the consult, especially maybe like a specialist. For example, we have a dermatologist. It's kind of hard to write all or to know all of the specific lingo relative to dermatology, but you can explain to them that that's perfectly fine, and that if they want to scribe their own note, that's great, and you can just be there to learn, because presumably you do have an interest in medicine, so you can just let them know that. And then at the end of the encounter, you can go through and make sure that all of the boxes are checked, and just let them know that, so that, and just let them know, they don't have to worry about all those little onerous tasks, that you'll make sure all of the right boxes are checked and all the data is filled in correctly, and they can just worry about diagnosing and treating the patient. So next thing is you need to figure out who your provider's next patient is, since of course the clinic is a walk-in and the patients are not pre-assigned to a certain provider. To do this, you will need to physically get up, or this could be you or the interpreter, y'all just need to work that out. One of you needs to get up and go to the waiting room to look on the patient list for the next patient. Normally the list has the patient who has most recently been called back to be seen by a provider already highlighted. But it is best to confirm with the clinic coordinator managing clinic. You'll need to confer with the provider as to whether or not they'd like to review the patient's chart before the patient actually comes in. In my experience, they usually do. So to access the patient's chart, go ahead and click on this Charts tab over here, and then type in any part of the patient's name. So I already typed in test patient here so that I'm not publishing real people's information on the internet, but you're going to type any part of their name, and remember that it can sometimes, especially for Latino patients, be difficult to find their name because they might have several first or last names, and sometimes the waters get muddied as to which names get added into which slots in the profile when they set up the account. So if you can't find them by typing some part of their name, try their 8-digit date of birth. And it's very important that it needs to be their 8-digit date of birth, or else it might start to look for the chart number instead of the date of birth. So this is my favorite little test patient, so we'll go into her account. So once you find the chart, you're going to want to show the provider at least 3 things. One is going to be the chief complaint, and I'll show you where that is in a second, and as well as the other 2 things. To get to the encounter will have already been created by the triage/intake people, okay? So that's going to be the, oopsies, we'll go to today's encounter. These are all their past encounters, and you want to go to the one for today. So click on that one, and the staff will have already made it. Here you can see one of those 3 things I was mentioning, the chief complaint. The other 2 are going to be their in-house tests. Those are tests that we can do in triage, such as a blood glucose, A1C, hemoglobin, pregnancy test. All of this is urinalysis. And we don't hardly ever do cholesterol testing because That's the only service we offer ever so often. So then, and then the third thing is their vitals. So this is a very important area, and it's all going to be in these tables up here, and their past readings are going to be going this way. Now, so those are the three things you are always going to show, but there are a couple of other things that might come up. First of which is lab results. If they're there because of lab results, you always need to go down to the very bottom of the encounter and find those lab results. They're going to be under attachments. Again, the staff should have already attached the lab results to the encounter. And the way that you'll find it formatted down here is the patient's last name, their first initial, the type of lab, or the type of document that it is. So it might say lab result, it might say encounter, like an old note that got scanned in a long, long time ago. It could say prescription. They made a copy of the prescription just to have that on file, a lab order, all kinds of, whatever document type it is going to be in the name of the document right there. And then it'll have the 6-digit day that it was made. So you can click on that and show it to the provider. Yay, you found the lab results. And the reason it says again is because there are other lab results in here, and I will show you how to find those. So to make this bigger, you just X out that box. Many providers would be very thankful if you were to make that a little bit bigger for them to see. So as I was mentioning, there are older lab results in here, and there's two ways to find them. There's like the official way, which I'll show you, and then there's the shortcut way, which I really like. So the official way is go to Timeline, go to Documents Pending. So any document that has been scanned and loaded into the system should be here. It might be under document signed, but at the current moment, we don't have a great system for the pending versus signed documents. So I'd always first check in pending. And then you can see here are these older lab results from 2018 that you can access from that screen. Notice that as you open documents, they stay open in this tab under the patient. If you open another patient, then you can have more of these tabs under that patient's chart. The shortcut way I was talking about, which I rather like, is to scroll down to the bottom of the encounter before it's signed and pretend like you're going to attach a document. And for whatever reason, that it allows you to see all the documents that have ever been attached to any encounter. And so all you have to do is click on this little icon and it'll pull them up. So some physicians don't like this view, but if you're just looking for something quick, there's that. All right. One more thing I'd like to note is if the physician or provider of any kind wants to see an older encounter, you can just back out and go to here and open it to show them. If there was an encounter that was done before 2015 that for some reason they want to look at, that's going to be an attachment that was scanned in under Timeline like I was showing you. All right. So now, we're going to move on to the second portion of this tutorial, which is the during the consult portion. The biggest thing that I do not want any of you to ever forget, tattoo it on your forehead if you need to, is that you need to change the seen by drop-down box to the provider that you're scribing for. Otherwise, none of this data gets attached to them, and it just creates a lot of problems on the back end. So if you're scribing for Dr. Fry, select his name. If you're scribing for Dr. Goodman, select his name. You get the point. All right, so the meat of scribing is going to be your SOAP note. SOAP stands for Subjective Objective Assessment Plan. Now I'm going to go through, and as we go through these sections, I'm going to describe a lot of things as to what goes in those sections, but I'm also going to try and give you just like a couple little, I call them knowledge nuggets to hold on to. Knowledge nuggets meaning go-to phrases that if you forget what goes in each section, that could, if as long as you have that memorized, it can jog your memory. So, subjective. It is asking you, what is the patient saying, specifically saying? So a way that helps me think of this is anything that we cannot verify sitting in the office right there. It's only the patient's word. So Your go-to statement here, your little knowledge nugget, is going to be either patient states, or patient denies. Obviously, if the patient said, I did not take medicine for this pain that I'm having or whatever, you would say patient denies taking medicine for pain. So very simple. You just write exactly what they're saying. In this video, in the description here, there's a link to a website with common medical abbreviations, and you can study those and use them as you feel comfortable, but until then, just report exactly what the patient is stating. And it's going to be hard sometimes to feel like you're keeping up with this, but especially at the Columbia and Old Percival locations, there's usually going to be an interpreter going from Spanish to English, and so the Spanish portion can give you time to keep up writing. And you don't have to record every single little detail, but you'll over time get the feel for what is the most important and what is not. But when in doubt, just write it down. So this patient we wrote, let's see, they're here for lab results. Let's go back up to the chief complaint. They're here for lab results. Let's also say that one of the chief complaints was also knee pain. Patient, let's say it's this. All right, so depending on how detailed the chief complaint is, sometimes I copy and paste it and make it the first sentence of the subjective. But let's say they are there for lab results. So one thing you can write is patient presents for lab results. You can say if the patient says more things about her lab results, you know, like that she's concerned about her weight or something like that, or her diabetes, you can say she states that she is worried that her lifestyle, if I can type, is making her diabetes worse. And then say, you know, you do get into a conversation about her lifestyle, you would put that here. She states that she works at a job where she has to sit down all day and doesn't get very much exercise. Easy. So whatever's being said by the patient about the problem, you can just write that right here. And as the physician asks questions and they answer them, you can just document that here. So now, next thing, objective. The objective is basically what the provider is observing. So there's a little disclaimer here, which is that you will need to ask the provider about this section because the stethoscope is not in your ears and you cannot hear what they hear. So even with that being said, there are a couple of things that you can reasonably gather, and I'll get to that in a second. So your knowledge nugget or go-to term for this section is tenderness. So tenderness is just reporting like an objective, we'll call it like a reaction, for example. Like if the provider pushes on something and the patient says, ow, you can reasonably assume that it hurt, right? So you could say the patient has some knee pain, so, and the doctor or physician or provider pushes on the outside part of the knee joint. You could say the doctor way of saying that, or sorry, the provider way of saying that is tenderness to palpation along lateral joint line. And the fanciness will come with time, but just remember the word tenderness. If the provider was pushing on the patient's belly and they get to the right upper quadrant of the belly and then the patient says ow when the doctor or provider pushes on it, then you would say tenderness to palpation over right upper quadrant. RUQ. Easy as that. So that's just a little bit about objective, right? I should probably say of the right knee. Got to say which knee it is, or which side and what joint. Another couple of little nuggets here. So there's tenderness. You've got HRRR, which means heart rate, heart regular rate and rhythm. So again, if the provider is listening to the patient's heart and they say, "Oh, sounds good," then it's reasonable for you to assume that HRRR is going to go in the objective section. Likewise, LCTA means lungs clear to auscultation. And again, if the provider listens to the patient's lungs and says they sound good, then you can reasonably assume that LCTA goes in the objective section. One last point, the provider may want to re-record some important lab values or make a statement about the lab values. So, for example, if the patient got a CBC and a BMP done, those are lab results that would have come in the attachment, i.e. a separate document. If the white blood cell count was particularly high, he or she, the provider, might want to re-record it here so that a future provider doesn't miss it, and or to help explain it to the next provider as to what this provider was thinking when they arrived at their treatment plan. So one little note you could say is just, and this could also pertain to the in-house labs. You can say A1C was high today, something very simple, or liver enzymes elevated, elevated per labs. Something just to make a quick little note, but that's only, if the provider is, it mentions it specifically. So we're going to move on now to the assessment and the plan portion. So for these two parts, think two sections for each of them. Like put it in your brain for the assessment and plan. Within each of those, you want to think about two things: the data formatting and the chronology. Data formatting and chronology. And I will explain exactly what I mean by that. So as for the data formatting, formatted data is data that is searchable. That means that we can pull that data from Practice Fusion and make reports out of it. And I like to call this data the clickies, because you can usually have to click around to record the formatted data. And the non-formatted data is anything that you type in a free text box, hence why I like to call it typees. So you've got the clickies and the typees. The typees are not searchable, and its purpose is simply to document what happened during the encounter so that future clinicians may read back to find out just that, what happened in the encounter. You'll see what I mean in a second, but just put that together in your mind, the concept of formatted data and then previous/chronologic data. So, in the assessment section, this is where you put the diagnosis. You have to actually select it. So that would be the formatted data portion of the assessment, i.e. the clickies. But first, you should look at their historical diagnoses. So that's the whole chronology portion. So what kind of data is it? It's formatted data, and you should look for the earliest diagnosis. So I'll show you. So let's say that the diagnosis for this patient is just simply knee pain, because we don't know for sure if they have a torn ACL or a torn meniscus or whatever. So let's just go back. So we're clicking because it's formatted data, and we're going to go look first to the previous diagnoses, because what will happen sometimes is for a patient who has a chronic disease, people who are not paying attention in our charting in that patient's chart, they'll just record a new diagnosis, which I'll get to that in a second if it's not on the previous diagnosis list. But then they'll end up with 4 or 5 or 6 diagnoses of type 2 diabetes, and it's not like they got it and then they lost it and they got it again. So you would go to the previous to avoid having that mess in their diagnosis list. So here it is, acute pain in the right knee. Apparently it happened in June of 2017. Great. Okay. Well, that doesn't work with the little fake encounter that I recorded, but that's okay. You guys will get the point. So that's the clicking part, okay? And you'll look for the chronology. Go to previous first. So it's a clicking and then previous. If the diagnosis that you're looking for is not in the previous section, then you will record a new diagnosis. So you literally just start typing for the diagnosis, and if you're not sure, you can ask the provider. It's very reasonable to ask the provider which diagnosis exactly that they want. Let's say arthralgia is a good one. So that just kind of means like unspecified pains. You can just figure out, based on which area of the body it is. And again, if you do not know, you can ask the physician or the provider. And here's the ICD-10 code, and I'll show you why that's important here in a second. If this is a provider who's new to Practice Fusion or who you're going to be scribing for a lot, you can have if you want to make your job a little bit easier, you can, instead of hitting the save button immediately, you can hit this little drop down and hit add to my DX list. So for example, if you're scribing for a rheumatologist and they are very frequently diagnosing people with rheumatoid arthritis, but it's not on their DX list, you could add it this way. Then I'll show you where the DX list pops up when you're trying to diagnose people. So you do need to fill out this information here. Is it acute or chronic? So it's acute, and I like to be specific. So if a patient says that it started 2 weeks ago, let's see, we'll say that today is the 1st. So then you just go back 2 weeks. So that's going to we're in July now. So 1, 2. Okay. So, and then you don't know when it's going to stop, so you just leave that. Then you hit save. Okay. This was the one that we just did for fun, so I'll get rid of that now. But that's just so you can see what it looks like. Now, if they have had acute pain before, I would put the start date as today, and we're going to pretend that today is the 1st. Okay. Fantastic. So, and I just want to show you now the diagnosis list that I was talking about when you're diagnosing. If it's not on the previous, you can always just go to my DX list, and that's where you'll find the ones that that you have previously added to the DX list. That's where they'll be. So those are the clickies, and you look for previous first, so it's the chronology part. Now, as far as the typees go, the typed information that is non-formatted data, for here you can type out any interpretations of lab results. So you can say maybe like, let's see, high blood glucose on this most recent lab result. Patient states she hasn't been following something that kind of, it's not just a stark statement of what the labs were. It's kind of an interpretation of the lab results. That's the difference between putting it in objective and assessment. Assessment is kind of like literally assessing the significance of the labs. And then the last section is your plan section. So your little knowledge nugget, by the way, for the assessment section was the diagnosis. So like, put those two things together in your mind. The assessment is where the diagnosis goes. And you won't forget that because it's written right there. So the last thing is your plan. So this is where all of the medications go, as well as any lab orders. So the clickies for this section, so remember I was telling you formatted data versus non-formatted data, and then you want to look at the chronology of the data you're putting in. So for the clickies portion, that's going to be the medications. Just like before, you're going to look at the previous medications, because if it's a medication that the patient's been diagnosed or been written for several times, you want to use that same prescription to basically write it again. If it's been like a year or two since the person's gotten it, feel free to, of course, just make a new prescription. But this is just a way of finding the data in the chart. So let's see. Looks like this patient is already taking Tylenol, because I probably did that in the past as an example to other students learning. But let's just get this off their medication list. So for the sake of teaching y'all, okay, let's just make the stop date 7/31/19. So then it will have stopped in the past. You see now it's going to be under historical medications, which I've used this example a couple times, obviously. So now we should be able to add some Tylenol to their medications list to treat their knee pain, right? All right, so you can look in their historical medications to bring up a new prescription, or you can hit record. So let's just use a historical one, Tylenol, and let's just make the start date today, and then the stop date is dependent on how long the prescription was written for. So here's where you can put in the directions. Usually these drop downs are pretty accurate. You just need to verify that, and you can type as needed in this box. But okay, this is fine. Say the physician or the provider dispenses 30. That means 30 tablets. And the day supply is the maximum, if they take the max number of tablets. So every 4 hours, that's going to be 6 per day, right? So how many times does 6 go into 30? It's going to be 5, so it's a 5-day supply. And the associated diagnosis is the one that we already did, and this is why it's important to go in order, because otherwise this diagnosis won't have shown up in there. The start date is today, and let's just say the stop day is going to be 5 days from today. So that's going to be, oh yeah, we're pretending today is the 1st, so it'll be in 5 days from the 1st. July 2017. Oh, no. All right, so August 1st, 1, 2, 3, 4, 5, great. And you just record it. Beautiful. All right, so that's the clicking around portion, the formatted data. You look previous first, and then if you need to record a new medication, you can do that in the record section. You can also get there this way, but it gets really messy. I don't like this. Do medications, then previous, then record. Similar to the DX list, this is the providers frequently prescribed medications. So just keep that in mind. If you need to record a new one but don't want to go searching around, you can just look in their frequent. After you scribe for the same provider for a long time, you'll get the idea of that. All right, and then the last thing is, all right, there we go. The last thing is the typees in the plan. So what is typed here in this free text box is going to be any documentation of lab orders. In a perfect world, we would attach these electronically, but we're getting there. So for now, we're just going to type them in the box. You can say lab order was given for a BMP, and I like to write the actual lab that was ordered. So it could be BMP, CBC, whatever's checked off on the lab order list. For a CBC to be done in 3 months. Whatever it is, okay? So lab orders, right? Documentation of lab orders, documentation of any specific advice given to the patient. So that's a big one. So patient was advised to exercise for a minimum of 150 minutes per week. I'm just making it up, but any advisements, and then any plans for follow-up. So patient was advised to follow up in 3 months after she goes and gets labs drawn again. She was made aware that at the time of her next visit, we will recheck her new labs to see if she qualifies for blah 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 treatment. So this kind of thing is something that a provider would write to basically as like a message to the next provider, so that if because we don't have the luxury of continuity like of care basically. So usually like if a patient comes in and is seen by Dr. A one day, the next time they come in they might not be seen by that doctor. So and that's true in the whole world of medicine, but especially in a free clinic setting. So they want to be really good about documenting the plan section so that the next provider that sees that patient doesn't have to go through that whole thinking pattern that the first provider went through. They can just kind of look and say, oh, all right, this is what they were thinking of doing. Okay, great. And these labs are showing this value, which means that we can go ahead and proceed with such and such treatment. So one little note, I talked to you about the importance of the ICD-10 codes that are in the assessment section. So you can just click on these, and there's the ICD-10 code right here. When a provider orders a lab, you're going to write the diagnosis in the the ICD-10 right next to the diagnosis on the diagnosis line. That's just a little administrative thing that you can help them with. And then at that time, when you do write that ICD-10 code, this would be a good time to confirm that the diagnosis in the chart is the same that's on the order form and is the one that the provider wants you to have in the chart. All right. I just wanted to say one note about the medications. When you are recording the medications, it is very important that you are diligent in filling out this information here correctly. The number of tablets, the start date, the stop date, all of that, because especially the stop date, because if you do not put the stop date, that medication will live in the patient's chart until somebody tells it not to, until somebody makes the stop date that day or whatever. And so what will happen is, say nobody catches it, and say it's like lisinopril or something that somebody would be on long term. If the patient came back in for a refill, but nobody X'd it out of their chart, like told the chart, hey, like this patient is no longer taking this medication, so let's get it off their current medications list. Then when the provider goes to prescribe it again, it's going to give them this annoying like duplicate therapy alert, and then you or them or whoever is going to have to go in, delete the old one or stop the old medication, then go back in and re-prescribe it. And so part of your job as a scribe is to kind of keep the chart clean and orderly. Right, so if you find something and you know the patient's not taking it anymore because of something they said, feel free to go in there and make the stop date that day, because at least on that day you know that they're not taking it and that they're out of it, and that helps clean up the chart. And then again, if they've got like 17 different diagnoses of like right knee pain, which this patient doesn't, but it really does happen, just choose the one that's the oldest and keep it, and then unless it's an acute problem. If it's chronic, then do this. But if it's acute, you're going to have to confirm that it's no longer happening. Anyways, so if it's chronic and she's got 4 or 5 diagnoses of the same chronic disease, pick the one that started the longest ago and then delete all the rest. Okay, I think I've done enough on my soapbox about this. All right, so now we're going to move on to the third and last portion of this tutorial, and that would be the after the consult portion. So after the consult, you're going to show the provider the note that you've typed and make any changes that he or she asks you to make. You will walk the patient to the front desk with any order forms or prescriptions. If the interpreter does not do this, again, you or the interpreter, depending on whether or not he or she is needed for that consult, can trade that responsibility on and off. And part of, now I'm going to get to this whole other little world, and the world that we are going to enter now is called the world of clinical quality measures. All right, so get your thinking caps on. So clinical quality measures are basically data that can help us know whether or not we are being effective in some of our endeavors that we take on when we see patients. So specifically, the eClinical quality measure I'm going to teach you in this tutorial is the blood pressure one. Practice Fusion, I think, has 17 of them that it's capable of recording, but right now the governing bodies that be are only requiring that we record 2. One of them is the one I'm about to show you, and then there's going to be a separate tutorial eventually on the other. So the one today is on blood pressure. The one eventually is on the influenza vaccine, and as to any others, stay tuned. So I'm going to show you this handout that I created, and these are available in all of our clinics if you forget, but I'm just going to walk you through it, and then you will be able to consider yourself trained on how to record the eClinical quality measure for blood pressure screening. So the first step is confirm that your provider has the Screenings, Interventions, and Assessments tab available, like enabled in their encounter. So what you can do is just go to Summary, Display Settings, and then just make sure that this is tabbed on. Okay, this toggle right here is on. What that does is it allows that section to be visible inside the encounter right here at the very bottom. Easy. Next thing is to determine whether or not your patient is eligible for screening, i.e. has not had that screening in the calendar year which you are currently in. So we're in 2019 right now. So what you're going to do is go to the patient summary tab and then look in their screenings, interventions, and assessment box, and you do not see that they've been screened for blood pressure. If they did, it would look like this: hypertension education. It may or may not say procedure, not that big of a deal, but the start date was done in 2019. So if it did say that, you could just quit, not go on, just you're like, okay, I'm done as far as this clinical quality measure goes. So if you get to step number 3, then follow my words very closely because this gets kind of confusing. If you make it to step number 3, you are going to add this code right here. Okay, and where might you ask? Oh, well, inside this Screenings, Interventions, and Assessment tab. So 391550009. Let's go here. So I'm going to go all the way down here. 391550009. Hypertension education. Fantastic. And you hit ordered, and that's all you have to do for this one. Now you might be asking yourself, okay, why are we doing this? Like, it says that we're claiming that we educated them about hypertension, but they were here for knee pain. Well, actually, during triage, every patient gets a handout, and that handout tells them basically which category they fall into. Are they hypertensive? Are they pre-hypertensive? Or do they have a normal blood pressure? And they get a little handout based on what their blood pressure was that day, and it tells them how they can, what they can do to control their blood pressure apart from taking medicine, and it's basically just a patient education handout. So every single patient is getting one of those. So we can always claim that they have been educated. However, if this is step 3, so if they've already been screened, you don't have to mess with any of this. But if they haven't been screened, you're always going to give them this code because that code is the formatted data way of saying, yes, we educated this patient about blood pressure. Then, of course, you hit change the status to ordered like I showed you, and then just hit done. See how it says ordered right here? That's how you know it was done well. Now, you can document in the plan section that basically that they were educated. So about their blood pressure. So what you can do is type in the plan section, type ... BP, and this BPE clinical quality measure thing will pop up. And all you need to do is delete the irrelevant text. So you have to, and what text is irrelevant is completely dependent upon what their blood pressure was that day. One way of doing it is looking on that little sheet they get from intake if they still have it out, but what I almost invariably do is just go ahead and go up to their vitals and look for that day. So their blood pressure today was 130/85, so that's going to be pre-hypertensive. You need to know the cutoffs for pre-hypertensive and hypertensive blood pressure. So if they're below 120/80, they are considered normal. If they're 120/80 up to 139 over 39, that is considered pre-hypertensive. If they're 140 over, it's 120/80 and then 140/90, not 30. So it'd be 29. So if it's up to 139 over, oh my goodness. Here, hold on. Let me get it out for you. Here I am saying you need to memorize it. 120/80, 90. So it'd be 89. So 139/89 is the highest you can be and still be considered pre-hypertensive. If you are 140/90 or higher, that is considered hypertensive. Okay, great. So, all right, so they are pre-hypertensive because they are between 120/80 and 139/89. All right, there it is. I don't know why that one was so hard for me. That's okay. All right, so we can edit this plan, and they are not good blood pressure, but they're also not high blood pressure. So we know that they're just at like the risk, they're in the danger zone. So you can get rid of this little label. That's just for you to know which paragraph to delete. Now, this is a very important nuance. Sometimes the conversation of the encounter does not lead itself to the patient's blood pressure. Sometimes they're just very mildly pre-hypertensive and the patient is there for like a million other problems, and you just don't end up talking about their blood pressure, and that's okay. So you just, if that is the case, you delete this sentence here where it says that they discuss the pertinent risks, they meaning the providers, with the patient. If not, you can just leave it there, but, oh wow, I Command Z and everything came back. Interesting. If not, you can just leave it there. But we're going to say that we didn't talk to our patient about it today, and that's all right because you can still leave the rest of it because the rest of it is still true. The patient was provided with educational literature, and they were told to advise to follow up in 1 year. They were told it because it's actually listed on the blood pressure information handout that they get during intake. So back to our little chart here. When in doubt, you don't have to rewatch this video. You can just go back to this document that is available at the clinic, okay? So we already put in this code. We changed the status to ordered. We put in the appropriate information and deleted the irrelevant text. Check, check, check. Now, we already determined that the patient is pre-hypertensive. So we also need to add this code right here, this 183-627-004. Let me see if I can remember. 183-627-004. Yep, okay, so that is just the structured way of documenting that we told them to follow up in 1 year. So you change the status to ordered, and the reason is finding of hypertension, and add. Now the next logical question is, well, what if they're not pre-hypertensive? What if they're actually hypertensive? That means 140/90 or higher, right? Okay. So you are in that case, if you have to ask yourself another question, which is this their first reading or their second reading in the most recent 12-month period? Okay, so I don't think that actually works with this patient because I've said that their blood pressure was really high for a long time. So let's just say it was really high today. Let's call it like 160. Whoa, not 260. By the way, if the systolic number on top qualifies them as hypertensive, but the diastolic number does not, always go with the systolic number because that is the more clinically relevant number. So now we're pretending that they were hypertensive for the sake of me showing you. Oh, that was not what I wanted. For the sake of me showing you how to document the hypertensive case. So then you're asking yourself, okay, they're hypertensive, and is this their first reading or their second reading? If it's their first reading, all you have to do is go down here. This was when we were pretending that they were pre-hypertensive, so let me just delete this. If they are hypertensive for the first time, follow this little thing, hypertensive for the first time, you're going to put in this code just the same way that you put in this code when we were pretending they were pre-hypertensive. If they're hypertensive for the second time, you do not need to put in this code. This is where people get very confused, so please pay attention. What will happen is we'll get a patient who's in the office for the first time, right? And they have been hypertensive for years and they know that, even though it's our first time seeing them. What we consider a reading is only readings that we've done in our office. So we do their reading, they're hypertensive, and it's our first time, seeing a recording of a hypertensive reading for them. But they know they've been hypertensive for a long time. So the physician or a provider might prescribe them medications, even though it's their first time there. And so people get confused about whether they need to add this code. But you do need to add the code because it's their first reading that we know of officially. So what will probably happen is the physician or provider is going to prescribe the medication, and since it's their first time at the clinic and it's our first reading of knowing that they have hypertension, you're also going to add this code. And that code is just the structured way of saying that we've told them to follow up in 4 weeks, which we have because it's on the handout we give. All right. So, and then once you add it, it's the same way. So I'll show you what it looks like. Let's see, 183,623,000. 183,623,000. Did I get it? Yes. Okay. Follow up in 1 month, and it's the same thing you would just do ordered and finding hypertension, and that would whether or not they've had one reading or more than one reading is based on the last 12 months. Not calendar year, but the most recent 12 months. So our patient has had another hypertensive reading, right? So here's a hypertensive greater than 140/90. Here's another one just a couple days ago. All right, so they would not get this. Let me just go ahead and delete it per our little infographic here, right? Because if you're pre-hypertensive, you get this one. If you're hypertensive for the first time, you get this code. But if you're hypertensive for the second time, the WHO, World Health Organization, recommends that you order hypertensive medications, but you don't need to add this code to get your provider credit for this eClinical quality measure. I know it's a little bit hairy to sort of parse out the details, but if you follow this infographic, I promise you that you will not be led astray. And if you have any questions, you can ask some of the more experienced scribes in the clinic. And now for my last point, please, 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 please. this is something you cannot forget. Have the provider sign the note. And this is, I mentioned at the very, very beginning of this tutorial that this is, that there is one difference between my screen and the screen that you'll see when you are logged into your provider's account, and that is this button. This button will be this color orange on their screen because they will be enabled, they're allowed to sign charts because they have a medical license, right? So please do not forget to let them sign this note. Otherwise, everything you did was for nothing, and it's just floating out there in cyberspace, all the data, and it's not being recorded, and that's just not what we want. So I will leave you with this last thing. I recorded a sort of shanty, it's a 2-minute long fake little like patient encounter so that you can see me, and I'll scribe as it is playing. Let me turn the volume all the way up. It's just like a little voice memo on my phone. And I am the patient and the doctor, so try and keep up with that, but I'll go ahead and scribe while we're listening to this.
Hey, what brings you in today? Well, I twisted and fell on my knee 2 weeks ago, and it still hurts. And sometimes I feel like I have to limp in order to get around without making the pain worse. Okay, have you ever done this before? No. And you said that you did it while you were playing soccer? Yes. Okay, have you seen any other healthcare providers for this problem? No. Alright, have you taken any medication for this problem? I took ibuprofen when I first injured the knee, but I haven't taken it recently. When was the last time you took it? About a week ago. Okay, did it help you when you took it? A little bit. Would you say the pain has gotten better or worse since it originally happened? It's gotten a little bit better, but it still hasn't gone away. Okay. Alright, well, why don't you take a seat up here? Okay. Does it hurt when I push right here? Ow. Okay, alright. Well, what we can do is go ahead and get you an x-ray, make sure everything's okay structurally in your knee, and then I'll just write down this name of this knee brace I can give to you, and you can go pick that up at Walmart, and I will write a prescription for extra strength Tylenol just in case the pain comes back at any point in time, and you can just take that as needed. Alright? Okay. Alright, well, we'll send you with this lab order here for an x-ray, and you can take that up to the desk, and as well, you can take this prescription with you, and the girls at the front desk will help you out with that. Alright, great. Thanks. No problem. Bye.
Okay, so you heard that little vignette, and I just wanted you to see me kind of typing with that in real life. Let me finish this portion right here. A lab order was given for x-ray of the right knee. Advised to follow up after the results. She was advised to wear a knee brace and was given the name brace that she could purchase at Walmart, and then you might want to put like the name of the actual thing that you wrote down. Alright, and then of course you do your blood pressure, BP, all of that like I showed you before. Based on her blood pressure, I'm not going to go into that whole thing again, but we already entered that medication, and make sure it says as needed. Alright, so that's just how you would do that. Again, just write what they say. Write what they say. If you're confused, just write what they say in that little subjective section. But I will give you my last soapbox here. Seen by, gotta change it, and you gotta sign the note. All right, when you're done with this tutorial, you can go ahead and take the quiz, and once you get 100% on that, you are good to go to scribe in the clinics, and you'll be hopefully advised by an older scribe, somebody who's doing it for a little bit longer, until you get the hang of it. And as always, please feel free to ask questions of any clinic staff and of any of the providers that you're working with. Good luck, y'all.